Oh, it's great to be here. Can you guys hear me okay, or am I projecting? This is a very difficult room because it's more long this way. So I'm like, whoop, whoop. All right. I'll try and talk. If you can't hear me, raise your hand and I'll yell. Okay. Well, thank you so much. I very much appreciate being here. I don't know, maybe save the best for last. Who knows? Or we'll see. But I was asked to talk about and explain to you some aspects from the surgical standpoint of what is involved in pleural surgery. Again, I'm from the NIH. It's a pleasure to be here. This talk is for you guys, so if there's, I'm happy to make it interactive as well. We can take questions in real time. And what I plan to do is try and give you, from my perspective, an overview of what is involved with pleural surgery, with a focus on the patients and the folks and the community that is afflicted with this disease, okay? So to start out with, again, what drives surgery is anatomy. So to kind of understand what is entailed in pleural mesothelioma surgery, just give me a second to adjust my screens here. We need to go back to Anatomy 101, and here everybody, I hope, can understand this analogy. We have a fist in a balloon, and the pictorial is meant to represent, if you can think of the fist as your lung, then that will help explain what mesothelial and pleural surfaces, and actually this is analogous for the peritoneal situation as well. And what you'll see is the layer of the balloon that sits directly onto the fist or the lung surface in this case is what we call the visceral pleura. And then the other side of that balloon, the other surface is anatomically what we call the parietal pleural surface. And then that space in between is the intrapleural space. And under normal conditions in humans, none of us have this space. It's a potential space, but it opens up during surgery and when we deflate the lung. But it's very important to understand because it shows up when mesothelioma is an active disease. Okay, so I hope, and then here analogous to that, then now you'll understand what all of these different pleural membranes and mesothelial surfaces that are named according to their anatomic location in the body. And just for reference, this is the front, the sternum, the rib cage, and then all of the blue areas represent these pleural surfaces that are named according to location. All right, so pleural mesothelioma is a very difficult type of tumor. It's a surface cancer. And since these mesothelial membranes cover many anatomic regions, as I've just defined, mesothelioma can form in the left chest, the right chest, as well as the middle chest, which we call the mediastinum. And then, as some of the earlier speakers alluded to, there's many surfaces in the body. So there's pericardium, which is surrounding the heart. So that's a heart form of mesothelioma. And then there's even down by the testes and the ovaries, there is also mesothelial coverings that form these ultra-rare versions of mesothelioma tumors throughout the body. And what or from the mesothelial lining, these mesothelial cells, the tumor grows there, and it often starts out early on as a flat sheet, a thin sheet, and it gradually spreads outward in a centripetal fashion. And then later in the course, only then does it increase in thickness and really become a huge problem. And unlike many, many solid tumors, like breast cancer, colon cancer, et cetera, mesothelioma has a unique property early on that it grows and it stays confined in whatever anatomic compartment that it originates from. It usually doesn't metastasize very early on, and so that forms some kind of unique conditions that continue to challenge us in terms of treatment and diagnosis. Okay, so here I'm going to show you again, and if you hear several speakers repeat the same thing, it must be true. Okay, so anatomic features of this unique tumor are very characteristic on imaging study scans. So oftentimes when patients show up initially, the basic kind of imaging study is a chest x-ray. Here I show some examples. This is an example of a late stage disease. You can see from a front-on view, the tumor kind of forms this envelope. It's pretty thick. It encases the lung. This is the normal lung, and you can see all that hyperexpanded lung, and here you don't. This is actually more often kind of what a lot of mesotheliomas can appear like on chest X-ray. A lot of our imaging studies don't capture the thickness aspect very well, and so here, in fact, a lot of the imaging underestimates the total tumor volume of mesothelioma at any given time. And here you can see what is actually an advanced case of mesothelioma, but it actually appears, it's misrepresented as appearing quite thin. And then commonly patients will also develop a lot of fluid in that intrapleural space. So you've seen several examples of CT scans, so if you haven't had it explained, I hope this drives home the point. These are all computed tomography, or CT, and positron emission tomography, PET. These are the most common imaging modalities. They take cross-sections across different sections of your body. And here, because you're looking from the feet to the head, the sides of the images are reversed. So the right side appears on the left screen, and then with the PET, you get the color overlay, and wherever there's color, there's tumor. So that, I'm sure, as patients, you've been shown some aspects of these. And then here, let me show you some unique features from the surgeon standpoint. So these are intraoperative views. And remember that fist in the balloon, so the camera is actually physically inside the intrapleural space, and now you're looking outside. So in one direction, you'll be seeing that parietal pleural layer, and then in the other direction, you'll be seeing the visceral pleural layer, which sits on and invests the lobes of the lung. So here, what allows us to get into the intrapleural space is we collapse the lung intraoperatively, and then we're able to look. These examples here show early stage tumors, so they're quite thin. These are the white plaques, so wherever you see white, those are the mesothelioma deposits. You can imagine over time they'll continue to spread outward and coalesce. On this side, I show some examples of more unfortunate advanced stage tumors. Here, as the tumor thickness increases, you have such tumor volume that normal anatomy is obscured. You can't make out ribs, you can't make out muscle. Here you can sort of see lung. In this example down here, you can't even really appreciate what is lung and not lung because there's a fairly thick investment layer on the visceral pleural surface of the lung at this point. Okay, so that's what it looks like in different versions. Let me show you. So in the crux or the Achilles heel for surgery is that the limitation is that surface cancers like this, we have very inefficient ability to remove all of the disease down to the very last cell. So in essence, what we end up having to deal with is residual microscopic tumor deposits. These are usually left behind, and the surgeon can't see it with the naked eye. And so our general objective, anytime that we entertain curative intent surgery, is to accomplish removal of all visible or palpable tumors. And this is what we term in the lingo macroscopic complete resection, or an MCR. And that's what a lot of if you read the clinical trial data papers, that's what the surgical objectives are. And I put here everybody, maybe everybody hasn't removed old wallpaper, but that's sort of the physical constraint of what it takes to peel pleura off of the chest wall. And here I couldn't get a good visualization of what the actual tumor is, but I'm showing you an analogous view of actually, this is normal pleura, and even then, Mother Nature intends for that pleura to stick onto the chest wall, so even the normal tissue is hard to take off, okay? So just to give you an appreciation of that. All right, so these are the definitions when you're talking in terms of treatment, and for those that do go to surgery, these are the terms that you'll hear a lot of the surgeons bounce around. And so EPP, extrapleural pneumonectomy, what this entails is removing the entire left or right lung, and at the same time, along with that lung, comes all of the surfaces that are connected to the lung in the chest cavity. And when it includes the heart covering or the pericardium and or the diaphragm muscle, all of these surfaces are included in what is termed an extrapleural pneumonectomy. This is the most kind of aggressive surgical intervention that we have for this disease. And every once in a blue moon, still in the modern day, we have to rely on this particular surgical strategy to achieve tumor removal. Now, in contrast, the more common modern day procedures that are being performed in North America and around the world are what are called pleurectomy decortication procedures, PD for short. And in contrast to the EPP, all of these pleurectomy decortication procedures retain the lung. The primary objective is to strip off the tumor from all of those anatomic surfaces that I've mentioned. When the pericardium or the diaphragm need to be removed in the process, this is the big difference between what we call an extended pleurectomy decortication and the standard pleurectomy decortication. Okay, so now I'm going to move you into, so these are what the definitions are, and then, hang on here, my slide is not moving, oh, there we go. Okay, now in the next series of slides, I'm going to depict what are the major surgical steps that are involved in actually accomplishing the hard work of removing the bulk tumor. So to gain access, typically we use what is called a posterolateral thoracotomy, and this involves making an incision along the side of the chest wall, usually at a low level, 6th, 7th, sometimes the 8th rib space. In the process, we actually physically will cut out a portion of the rib, and this will allow us adequate working room for the surgeon to get their hands in as the ribs are spread with retractors. Okay, and this is commonly what's used as opposed to all those video images that I showed you with the camera, which were more in the early stages of diagnosis as opposed to treatment. Okay, and then kind of what is meant by pleurectomy, again, to strip off that entire parietal pleural layer from the bony rib cage. So here the picture shows typically what happens is that the surgeon will then develop a dissection plane between the ribs and the parietal layer that contains tumor. And then here you can see, starting from a small space, gradually there will be enough working space in between as the lung circumferentially gets freed off of the rib cage. The surgeon is able to physically put their entire hands inside. Okay, and then once the tumor casing is freed from the rib walls, i.e. the pleurectomy procedure, then we have to contend with removing the other side of the tumor and peel that away from the surface of the lung. So here again, just to orient you, the white is the tumor completely encasing the left lung. And then the insert here is meant to illustrate, so we're trying to save the lung, and in the process, peel that orange peel or the banana peel, however you want to think about it, and peel that off. This is that visceral layer of tumor from our short anatomy session just a moment ago. Okay, so this is what a pleurectomy decortication entails. And then here, just to depict and explain, so in contrast then, that extrapleural pneumonectomy, at the end of that procedure, there is no lung. Okay, so pneumonectomy means remove the entire lung and all the lobes. And then in cases where we have to remove, completely remove the pericardium and or the diaphragm surface, we'll reconstruct those to maintain the normal anatomic relationship between organs. And most often that's the material that we insert is Gore-Tex material that we will sew in, and that's what these white patches are. Okay, and again, so the major limitation of leaving microscopic residual tumor deposits is that eventually, if you wait long enough after surgical debulking, tumor will regrow. And this is the Achilles heel. I show here an example from some historical case series that the recurrence rate can be anywhere from 20-30% upwards of 70-80% depending on how long you live after surgery. And typically when it comes back, it'll come back in the same area where we did the original surgery. So now I'm going to depart. So that's all of the surgical stuff. And I want to talk about, so that in line with all the previous speakers, I want to talk about some stuff coming down the pipeline. There is a lot of ongoing research in the background to try and really improve the outcome of surgery, because point counterpoint with all of the other speakers, drugs, radiation, etc., we still haven't come up with a good solution to completely eradicate this thing and make it durable. And so there is many, many types of new technology that are being applied in the adjuvant setting. So adjuvants are interventions or treatments that are given immediately after the primary treatment. In this case, as a surgical adjuvant, there's a lot of kind of new technologies that are looking at novel ways of killing these microscopic tumor deposits. So here, and then again, I'm not going to get super technical, but I'm just going to show this slide for education purposes. I want to briefly visualize and summarize all of the three kind of grand categories of major surgical adjuvant modalities that are being investigated and or currently being trialed in humans. They are adjuvants that involve installation of direct therapeutics. There's a class of agents that rely on a novel type of delivery vehicle to get either a drug or a brand new kind of agent, anti-cancer agent, to the place where we want it to go, and this is the cancer cell in particular. That's been that is a major limitation of all treatment modalities mentioned today. None of the systemic drugs can specifically target cancer cells. Even the targeted therapies like the bevacizumab, anti-VEGF antibodies don't completely concentrate all of the drug exactly where it needs to go. So that's always the Achilles heel of therapeutics. And then the third kind of grand category of adjuvant therapies is what we term drug-device combinations, and I'll show you what photodynamic therapy is. But all of these are meant to improve the macroscopic effect of surgery to be able to target the microscopic residual cells and completely eradicate the tumor. So here, the most common form of the direct adjuvant type of adjuvant therapy is what we call heated intrathoracic chemotherapy. This basically involves pouring in immediately after surgery into the chest liquid drug chemotherapy. You've heard many of them. Cisplatin is the most common. And then typically the drug is heated to a higher temperature, and then it's circulated around the chest for some duration, typically an hour. And what the idea here is that exposure of the cancer and the chest cavity directly to higher concentrations of the anti-cancer drug may have some beneficial effect to killing off whatever else the surgeon could not see and remove during the surgery. All right, and then PDT, photodynamic therapy, what this technology is, very briefly, is what's injected into the body is a special kind of a photochemical drug that circulates throughout the body, and some of it will eventually concentrate wherever the tumor is. And this is given before surgery. Then the patient undergoes surgery, all the debulking is done, and then during surgery, what the surgeon will do is have access to the device part of this strategy, a handheld laser operating at a specific wavelength, and then what the surgeon does will move this laser wand all over the chest where he thinks that there might be residual tumor. And wherever the specific laser light will shine, it will excite that drug that has now had some time to percolate into the tumor. And once that chemical agent gets excited with the laser light, it will cause a photochemical reaction, and then that's meant to be toxic and will kill all cells. Now, the big disadvantage is that this will kill not only tumor cells, but it'll kill normal cells depending on how much exposure to that laser light that the surgeon decides to give. So this is a difficult technology to consistently apply. And then here, I'm going to finish with the future. This is a lot of this stuff is in the drug delivery strategy. A lot of this work has not reached human testing or trials yet. Most of it, all of it is in animal studies, but it's really, really exciting technology where the delivery agent carriers are engineered and designed to zone in specifically on cancer cells only. And here I'm going to show an example of a gel called a surface fill hydrogel. it's engineered to adhere and mold to the surface kind of topology of the human body, of the tissue where it's applied. And then based on its design, it preferentially will stick a little bit tighter to where cancer cells are. And then during the process of this gel being reabsorbed by the body, it will release special type of focused nanoparticles that can carry new agents that can then kill off all of these invisible residual tumor deposits that we can't see. And that's what meant to be here in this cartoon. You can see is that the big advantage is if you can target all of the cancer cells and don't hurt the normal cells, the toxicity level is much better and the efficacy is much greater. A lot of this technology is highly promising, and we're anticipating in hopefully the near future, some of this technology will be reaching folks like you. All right, and that is it. I hope I finished well under time, and we have plenty of time for questions. But again, so what I hope to have illustrated is that this is a very tough surface cancer. Very complex because of the anatomic kind of relationships in the body that we're tasked to remove. But currently the surgical objective is macroscopic complete resection. The most common operations are the pleurectomy decortication procedures that are meant to strip off the tumor and preserve as much normal tissue as possible. And as part of a multi-modality strategy, this may be an effective component of treatment that has a clear benefit for certain highly selected patients. And namely, that's folks with early stage tumors, low volume tumors, young patients with mesothelioma that can undergo the rigors of surgery. I think there may be certainly a subgroup that is hard to argue that surgery doesn't benefit. And then with an eye to the future, many surgical adjuvants with promising technology strategies are in development, and I hope they will be available for those in the audience in the near future. And with that, I'm open for questions. Thank you very much.
We have a couple questions on this side of the room over here. Joe Winter? Okay, we'll start here and we'll go that way.
All right, thank you.
It's on.
All right, thank you. Just a quick question. So if surgery has been done in the early stage, but after like a while and the tumor came back, can another surgery be done, or it has to go through that normal treatment process?
That's a great question. Can we do redo surgery in, again, highly selected, case by case situations? The general answer is yes. The general answer is we do them, and there's another cohort of people that come back for redo surgery as well. But then the question becomes, and like with all the other kind of modalities you've heard, after the second and third line drug, it gets harder and harder. So after the second and third reoperation surgery, it continues to get harder and harder. Same with radiation. Thank you for that question.
Thank you very much for your presentation. My question revolves around, after a pleural decortication, will the lung fuse to the chest wall?
Yes, in the sense, I'll split hairs with you in terms of definitions, but when we do a pleurectomy decortication and strip off all this tumor, there's a lot of raw surface, and so when the lung re-expands, as with all surgeries, you're going to have after surgery scar tissue and healing effects. So by definition, all things will quote unquote fuse. But that doesn't mean that you can't, to address the first question, it is still possible to reoperate, after a first operation. But in general, yes, that's what it's designed to do, is things will naturally scar in, and the lung will kind of re-stick to the rib cage.
Thank you. Thank you, Dr. Hoang.
Thank you so much.